Good evening, everybody, and welcome to our webinar tonight, Gender Affirming Care. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to Elders past, present and emerging. We have three presenters for you tonight. Dr. Sujata Allen, who's a GP from Armagen in Armidale. Dr. Joe Majua, who's a sexual health physician in Newcastle. And Associate Professor Katie Wynne, who's a senior staff specialist in endocrinology, also in Newcastle. We do have a chat box, so if you have any questions, please type them in. This session is being recorded and will be available in our education library on our website, along with a copy of the slides. I think that's all you need to hear from me, so I'll hand over to Sujata.
Thanks so much, Jenny. Thanks for organising it. So my name's Sujata. I'm a GP in Armidale on animal land at Armagen Aboriginal Health Service. And Katie and Joe will be joining us soon. They're going to be running a little bit late, but I'll kick us off and then they'll join when they get here. So I'll just share my screen. Cool, so that's all working?
Yes, it is.
Great. So, today we're going to talk about gender affirming care for GPs. And I think the reason I wanted to set this up was because I've been doing gender affirming care as a GP for the last couple of years, and I feel like it's an area that we don't have much education about, and also it's I think it's a really important area for GPs to know about because there's a lot of need out there and a lot of vulnerable people who really need the support from GPs. And also it's quite we can do a lot of this care in the context of general practice as well. So firstly, I also wanted to acknowledge that wherever we are in Australia, we're on Aboriginal land and sovereignty was never ceded. So the learning objectives are really to gain knowledge of the unique healthcare needs and challenges of trans and gender diverse patients and how to make your practice more supportive. And we're going to talk about the informed consent model for providing gender affirming care. Professor Katie Wynne is going to talk about the New South Wales Health Framework for trans and gender diverse people under 25 years. And overall, I'd like people to gain knowledge and confidence in prescribing gender affirming hormone therapy if that's what the patient needs. And so a lot of this information in this talk, pretty much all the information, a lot of it comes from Health Pathways, which is actually amazing, especially the transgender health pages. And I believe Katie has written a lot of those, so she's a real expert in this area. But there's also a really great AJGP article from a few years ago, and also got a lot of information from the Australian Informed Consent Standards of Care from AusPath, which is the Australian professional body for trans and gender diverse people. And just to point out that New South Wales Health has an LGBTIQ health strategy, which lays out sort of best practice for New South Wales Health, and then this new framework, which was released quite recently, which we'll talk about a bit later. So just to plug the Health Pathways, I'm sure you all know about it, but if you don't, go on and use it. It's really amazing. And basically, it's a really great support, especially with this kind of area. So what is trans or gender diversity? I guess it's important to say that it's being trans or gender diverse is not a mental illness. It's actually just part of the rich experience of human diversity, and humans come in all shapes and sizes, and trans and gender diverse is one of those diverse experiences. And overall, it just really means that people who are trans or gender diverse, they don't identify with the gender assigned to them at birth, the sex assigned to them at birth. And it's different from sexual orientation, where people could be trans and identify as a straight person or bisexual or different kind of sexual orientations. Being trans doesn't necessarily, it's not the same as a sexual orientation. So the ICD-11 criteria I like much more than the DSM criteria. And in terms of diagnosis, we're in the GP clinic, we can definitely use, this is a recognised standard diagnostic tool. And I'll read it out just because it's sort of useful to get your head around. So gender incongruence of adolescence and adulthood is characterised by a marked and persistent incongruence between an individual's experienced gender and the assigned sex, which often leads to a desire to transition in order to live and be accepted as a person of the experienced gender through hormonal treatment, surgery, or other healthcare services to make the individual's body align as much as desired and to the extent possible with the experienced gender. So I think it's important because it really centres the person's experience. It doesn't actually, so they moved, in ICD-11, it moved out of mental disorders into sexual health conditions. And really, diagnostically, all that is required is that there is a marked and persistent incongruence between the individual's experienced gender and the assigned sex. So that's something that the patient will tell you. And so it sort of really centres the patient. It's very sort of patient-centred diagnosis. And a lot of the time it is so, like a lot of people do have distress or impairment or kind of mental ill health because they feel like they're not being perceived in the right gender, but it doesn't necessarily need significant distress or impairment to fit this criteria. And so, yeah, places gender incongruence as part of the normal diversity of human experience. The DSM-5 criteria, pretty similar, and it's basically, similar kinds of things, although it also has clinically significant distress or impairment associated with it as well. I wanted to go through a few examples of terminology because it might not be something that everyone is familiar with. So being trans or transgender is basically an umbrella term for the whole range of individuals who don't identify with their birth sex. So that could be a non-binary person who doesn't identify as either gender, or it could be a trans person who identifies with the gender that's not their birth gender. Gender diverse just means people who do not conform to their society or culture's expectation for males and females. Often use AMAB, so assigned male at birth, thought to be male when born. Assigned female at birth, it's self-explanatory. Cisgender is someone whose gender identity matches their assigned birth sex. And non-binary, some people don't identify exclusively as male or female, and they might use pronouns they or them to kind of illustrate that. There are some people who identify as agender, so doesn't identify as any gender. And then in the Aboriginal community, brother boys and sister girls is kind of the terms used by the Aboriginal Torres Strait Islander community for transgender people. So it's important to be mindful of the language because that's sort of part of making somebody feel comfortable in your clinic. So some things that aren't very appropriate and have been associated with discrimination are these kinds of terms like tranny, transsexual, transgendered, was a woman or a man, if they were a normal woman or man. So all those things are kind of quite dated terms, and they're not very supportive of the person. So try and avoid using those ones. So why is it important? So it's important to provide this kind of healthcare because it is a small part of our population, but a significant part. And the trans and gender diverse people have a huge burden of health consequences as a result of discrimination and stigma throughout society. So they're at much, much higher risk of family rejections, of social exclusion, of having bad experiences with healthcare. So not having their gender identity taken seriously or doubted or misgendered or just not being treated respectfully. Bullying and assault is a very real physical issue for some people. And all of this stigma and minority stress results in a higher level in the trans and gender diverse population, much higher level of psychological distress, suicide attempts, and self-harm. In overall, about 3 to 5 times higher. Especially in young people, the suicide attempts in transgender young people are 15 times the general population, and also all-cause mortality is 3 times higher. And that's really relates to people's experience of discrimination, both within the healthcare system, but also within the general society. So I think that's really, they're a vulnerable population, and something that if the healthcare setting is safe and appropriate, we can really change these kind of numbers and give people a much better life and outcome, which I think is very important. So there's different aspects of gender affirmation. So not everyone will want hormone therapy or a full kind of transition. Some people, so you can have different kinds of affirmation. You might have social affirmation, so change the name or the clothes or the hair to kind of reflect their gender identity. Medical affirmation talks more about hormone therapy. Legal affirmation, so some people will want to update their identity documents to reflect their experience. And then also surgical affirmation, so you could have gender affirming surgery, for example, top surgery, such as a mastectomy, or bottom surgery, like orchidectomy or genitoplasty. And not every trans person will be different in terms of what their goals are and what they actually sort of want out of their healthcare. And I'd really recommend, in terms of learning more about this Trans Hub, is really great. It's great information, both for patients and for clinicians as well. So I wanted to talk a bit about the informed consent model of care, because that's really the best practice model of care in providing gender affirming care. And informed consent, I mean, we all know about informed consent. We do it all the time. I thought it's useful to just go through it briefly again. So it's the person's decision, patient's decision, given voluntarily to agree to a healthcare treatment. And that's made that after you've explained accurate and relevant information and what are the alternatives, and the person has to have knowledge and understanding of the benefits and the risks of the proposed intervention. So again, it's very patient-centered, placing the decision to, like if we're talking about hormone therapy, for example, decision to start hormone therapy in the hands of the patient, as long as the clinician has made sure it's safe, there's no contraindications, and that it's been, all the risks and side effects and everything has been adequately explained. So it's not necessary for a patient over the age of 18 years to obtain any kind of gender assessment with a psychiatrist or psychologist before starting hormone treatment. So GPs can make the diagnosis of gender incongruence, like for example the ICD diagnosis, and genital, you don't need to examine anyone's genitals. You basically, by taking a good history and doing what we do every day in GP land, we can. It's part of what our scope of practice is. And it really again, it sort of comes back to the patient-centered care rather than the doctor telling the patient what their gender identity is. It's the patient coming to the doctor saying, this is my experience, I've felt like this ever since I was a teenager. I've been thinking about hormone therapy for the last X amount of years. I really want to go ahead with this. Can you help me in this process? That being said, if the person's wanting surgical affirmation, then they will need to see a psychologist or psychiatrist to get a surgical readiness letter to make sure that they really understand. It's almost a bit like a capacity assessment, or just that they really understand the impacts. I'm just going to pause briefly because I actually can't see the who else, the other presenters who are here. Are there other presenters that have joined us yet?
Yes, Joe is here.
Great. Joe, because I can't, when I'm presenting, I can't see anybody apart from the slides. So if there's things that you want to say, please just jump in there. And
okay,
I might hand you
thanks.
over. I might, when it comes to the more of the sexual health side of things, I might hand over a little bit more to you as well. So for young people, there's a few more hoops to jump through. And I guess what I do in my practice is that I would refer all people under the age of 18 years to Maple Leaf House because there's a more supportive multidisciplinary team. So people under the age of 18 years, they do need a diagnostic assessment by a psychiatrist or a clinical psychologist, and they do need a capacity assessment, and they need consent both from themselves and both their parents. So if they have two parents, both their parents and guardians. So it's a much more formal process. Even younger people under the age of 16, they might need assessment from the New South Wales Civil and Administrative Tribunal. And definitely under the age of 16, I'd be 100% referring to Maple Leaf House. In my practice, I refer anyone under the age of 18 to Maple Leaf House. And you can actually, Maple Leaf House. So that Maple Leaf House is a specialised gender clinic in Newcastle, and they accept referrals up to the age of 25. So when you first see a patient, so how do you assess them if they've come in sort of looking for support around their gender? So the first thing, obviously, that you do every day is take a history, and I normally start with take a gender history, including their preferred names and pronouns. So I guess I normally ask questions because they often come, by the time they've presented to a GP, they've been thinking about this for often a number of years. It's not like a decision they made last fortnight. So just a bit more of a history about when did they start feeling this way? Have they come out socially? What's their preferred name? What are their support systems? So some people have really great supportive families. Other people are really haven't even told their parents or whatever. So there's very big difference in that. And also goals, like what are they actually wanting out of their treatment as well. The rest of the history is pretty much what we would normally do with every young person anyway, or a new patient. So past medical, surgical history, mental health assessment and history is important. You want to do a HEADS assessment in young people, which I won't go over because everyone would know about that already. Family history, if they have actually started self-medicating or used any hormones before, what are they taking over the counter, allergies, drug and alcohol history, all the kind of usual stuff that we normally ask. Sexual health history, maybe I'll hand over to Dr. Joe Mazur for talking a bit more about sexual health side of things.
Okay, thanks, Sujata. Can you maybe give me a thumbs up if you can hear me okay?
Yeah.
Because I can see.
All good.
Joe, I think you've just accidentally muted yourself.
Oh dear.
There you
we
go.
All right. So I'm based in Newcastle at the Pacific Clinic, the Sexual Health Service, and where I do see people for gender affirming care, but age 25 and older, and there are some criteria around that. And in the past, I have also had some input into the multidisciplinary service at Maple Leaf House that Sujata was talking about. So I'm happy to talk a bit about the sexual history. There are some questions popping up in the chat as well, and I don't know if we want to address those as we go along or save them.
Yeah,
for
I can't actually see the chat when I'm seeing the slides. So if you want to I think it makes sense to talk about them as we go, unless it's something we're going to cover.
Yeah, yeah. Because there is well, the first one that popped up was a question saying, can you explain, who or what transvestite means? Do you want to talk to that, or would you like me to?
Good, you can talk to that.
I'll have a go. So, and look, I'm no expert on language and terminology, but and I'm sure as was explained earlier, tra- being transgender is about someone's gender identity, their innate sense of their gender as male or female or non-binary or something in between. Transvestite's an older term. I think we often we might talk about cross-dressing or about drag queens and drag kings, and this is sort of in that same area. So it's someone who might, in some circumstances, enjoy dressing in the appearance of someone of a different sex or gender, but don't necessarily identify as that gender in themselves. So that example of the kind of classic example of a drag queen might be someone whose gender identity is male, but dresses as a female, and it might be in the setting of performance, for example. Um, would you be happy with that kind of description, Sujata?
Yeah, and I think
Yeah.
I would. I actually don't know. Again, if I'm I'm also not an expert on language. I haven't heard any trans people use the words transvestite. I think it's quite an old term, so I
Yeah.
probably would stay away from it in terms of describing somebody. Like I'd
Yeah.
probably go transgender, but that's
Yeah, so
just me.
quite different to transgender.
Yeah, yeah, true. Yep,
Yeah.
yep.
Yeah, different setting. And I think in my experience now with people, who I know who might proudly say I'm a drag queen and I'm performing here or there, that might have been a term that some time ago they might have said I'm a transvestite, the sweet
Mm,
transvestite kind of thing. But that's not someone who necessarily, in fact, often does not identify as transgender. So
yeah,
they're different. So
yeah.
yeah. All right. And there was a question about, does Gillick competence apply for consent? And I think you touched on, well, we talk about the informed consent model, that really is for, well, it's complicated, age 18 and over.
Mm,
And certainly in the guidelines around suggesting an assessment for people under 18 really kind of doesn't quite agree with how we might apply Gillick competence for young people for,
mm,
um, for, I guess, potentially for more minor forms of medical care.
yeah, yeah. I think
Yeah.
the formalities that they need a capacity assessment, which is, I guess, a formal way of assessing their Gillick competence. Well,
Mm,
not even Gillick competence, but I guess a more formal kind of formal process rather than just um, a single clinician deciding if they're competent or not.
that's right. And if both parents aren't in agreement, it may be necessary to go to family court. So
Mm,
I think this is why there's a very strong argument for referring on people under the age of 18 unless you have a lot of experience in the area, um, about that consent process. So I
yeah,
think certainly in my practice, I would use informed consent for people aged 18 and above,
yeah,
um, who have no evidence of incapacity to understand the benefits and the risks of the treatment that's being discussed.
yeah,
Hmm.
yeah. Sure.
Yeah. So they were the only questions at the moment. And look,
Yeah,
talking about sexual health history with trans and gender diverse people, um, is really just similarly to anyone else in that history. Where I would always consider pregnancy risk. Um, and part of that conversation is also talking about the desire for future fertility, um, which may include for the patient themselves having a pregnancy or having children by other means. But that's definitely part of the history. And I know you'll talk later about pregnancy risk in anyone with a uterus. We still
mm,
consider there to be a risk even if they are on hormone therapy with testosterone. So then we might also need to talk about the need for contraception. And in transmasculine people, so people with a uterus who might be on masculinizing hormone therapy, a frequently asked question is what kind of contraception can be used, and really any method that can be used in someone who isn't trans is possible, but you usually stay away from estrogen-containing methods in case it sort of slows down or affects their masculinizing hormone therapy. So progesterone-only methods are completely fine, as of course are non-hormonal methods. So, I work in sexual health, so assessing STI risk is always another key part of what we do. And I think we'll talk about that on the next slide. And also thinking about HIV PrEP, is someone at high risk for HIV, because we now have very good, chemical prophylaxis to help prevent HIV infection. So we should definitely think about PrEP in all these consultations. And it's a bit sad that I leave this last, because working in sexual health, we're often all about the risks of sex, about STIs and pregnancy, but I think it's important to be a bit more sex positive and to ask people about whether they're satisfied with their sex life at present, whether they have any concerns about it, and maybe opening up that discussion for how sex drive and function may change, during the process of hormonal transition if someone does decide to go ahead. Doesn't mean you have to be expert at it, but I think it's worth asking the questions and identifying if people have concerns.
And just to plug that there's actually on the STI management guidelines, there's a page for trans and gender diverse people which lays out kind of screening and that kind of thing. So it's quite helpful.
Yeah, thank you. Yeah, they have guidelines sort of for specific populations, which might include men who have sex with men and sex workers. And there's certainly a section on trans and gender diverse people, and it talks about how you might take a history and what tests you might do. And then I think there's also a lot of information on the Trans Hub website that you showed before, which emphasises this parts and practices approach to sexual history. So, look, if you're offering STI screening, to be honest, in a sexually active trans person, my routine is actually, well, we would offer everybody a blood test for HIV and syphilis, and we'd screen for chlamydia and gonorrhea. And we can offer tests from the throat, bottom, urine, vagina, depending on what's appropriate for you. And you can self-collect samples. Would you like testing for any sites? Kind of leaves things open for people to say, or you can, if you're comfortable and the client's comfortable, go into the nitty-gritty about who's putting what where. And I guess I find trans people often have trans and gender diverse partners. So you can't really just ask, are you having sex with men or women? That's not good enough. So sometimes you have to talk about, do you have partners, with a penis, or partners with a vagina, or both? And talk about which parts of your body might enter parts of your partner's body, or vice versa. So thinking about body parts and practices can become important, rather than just asking about what sex partners are. Thinking about pregnancy risk often just comes down to, and I do ask, my transmasculine patients, and maybe I haven't met them before and I don't know what surgeries they have. I'll say, look, I'm sorry, but just to be clear, do you have a uterus? Do you have partners who have sperm? Okay, sounds like there might be some pregnancy risk. Let's talk about it. And it really, I think if you ask very openly to clarify what organs your patient has and what their partners have, people are very, understanding of the need to do that in this setting. Completely inappropriate at a party to say to someone, hey, what do you have down there? But, in this setting, when you're talking about sexual health, quite okay to ask.
Cool. So we'll move on to talking about what is gender-affirming hormone therapy. So we'll start with feminizing hormone therapy. So that is basically a combination of estrogen plus or minus an anti-androgen. And the typical changes that you'd normally expect. So there's some. So on the another plug for Health Pathways, on the Health Pathways site, there's actually a really great informed consent download. So it's got all the permanent changes, reversible changes, all the risks, all that kind of thing, and it's got a place for the patient to sign. So I use that for patients that I see. And then that it sort of is a reminder of all the things that you can talk to them about as well. But basically, the typical changes. So the changes can happen. They happen quite slowly and over a period of years. And so there's things like softening of the skin, decrease in muscle mass, and increase in body fat, decrease in sex drive, decrease in erectile function, and then gradually over time there'll be nipple and breast growth, slower growth of facial and body hair, slowed or stopped balding, and decrease in testicular size. And some of those changes are permanent, like the nipple and breast growth, for example. And the risks, so this is basically cut and paste exactly from those informed consent sheets from Health Pathways. And we, like, I think that's the thing that another reason I want to do this webinar was we, as GPs, we prescribe estrogen all the time to people who are on the pill or HRT. So we know all about this anyway. It's no different when you're prescribing for a trans person. So I won't go over all the risks and side effects because I think we all know that. There's a few specific things such as meningioma in a rare kind of a rare side effect with cyproterone, which is an androgen blocker. But pretty much all the estrogen side effects we talk about when we can send people to the pill, for example. So it's pretty straightforward. The types of feminizing hormone therapy that's often used. So you can have oral version, so just a tablet, generally starting with 2 milligrams a day up to 8 milligrams a day, gradually increasing. And then there's transdermal types, which is Sandrina gel, estrogel, transdermal patches. And there's also an implant, which is a compounded implant, which is available from some pharmacies. And I won't go over all the doses and everything now, because I think in real life you'd be looking up health pathways or guidelines for that anyway. But probably most of us have used these, even if we don't have many trans and gender diverse patients, we probably have used these products with cis women going through menopause or similar kinds of things. The androgen blockers, so there's two main ones, the spironolactone, which most GPs will be very familiar with, using it for things like heart failure, but it's the anti-androgen effect is what we use it for here. And starting off with a 50 milligram dose, you can use up to a 200 milligram daily if needed. And the cyproterone acetate, which is a component of one of the pills, I think it's Diane and those kinds of pills. But there's a higher dose tablet, which you can use just for the androgen blocker effect. The progestins, they're not used as commonly, but some patients will come to you saying, I really want to go on this progesterone. And so there's some, they're not recommended in the long term because of the side effects, such as depression, weight gain, cardiovascular disease, and breast cancer. But in some patients, they can help with testosterone suppression. And you generally, and there's anecdotal evidence that they improve the late stage of breast development, which is why a lot of people have heard about it. And some people want to go on it. And the progesterone that is used is micronized progesterone, which is like a body identical progesterone. In the trade name is Prometrium. Did you have any things to add, Joe, about the medications?
No, not at the moment.
Cool.
Yeah.
Awesome. So we'll talk now about the masculinizing hormone therapy, and in the case it's just testosterone. So again, the effects of testosterone sort of happen slowly over a year or two, but initially, like in the first couple of months, people will experience a change, so increase in their sex drive, decreased estrogen levels, so that that often leads to vaginal dryness, and clitoral growth, which is that's also a permanent change that happens, and then increased growth, coarseness of the hair, oilier skin and increased acne, increased muscle mass and upper body strength, redistribution of body fat. So kind of the same sort of changes that you expect in a puberty kind of change. The menstrual periods take a bit longer to stop, so often take up to 6 months after starting testosterone. And the voice changes start to happen about 3 to 6 months. They're also permanent changes, so the voice starts to crack and drop in the same way that a teenage cis boy will have those changes as well. And then after a year, you'll get more growth of facial hair and, of course, possibly the male pattern baldness as well. So the risks of testosterone, again, GPs might be less familiar with prescribing testosterone because we don't do it quite as often in other conditions. But there is a risk of polycythemia, increased risk of cardiovascular disease, or worsening blood sugar control. I guess all the things that we normally associate with the increased risk in cis men is sort of the same in a trans man as well. So worsening sleep apnea, osteoporosis, potentially liver damage, increased salt and water retention. And the practicalities are that GPs can start testosterone on a private script, but to access a PBS testosterone, you need an endocrinologist or a specialist to sign off on that under established androgen deficiency. And I know that some of these patients who are very straightforward might only need to see the endocrinologist once, or even have like a phone telehealth or a phone advice from a specialist initially to start the PBS process if they're very straightforward and then have other things going on as well. And there are some non-PBS options as well, which are the same cost on it because they're not even on the PBS. So in terms of the doses and the routes, so you have a transdermal option, which is Testogel or Testovan. Gradually, you start off with a low dose and then over time gradually increase the dose depending on the testosterone levels. I am Reandron, which probably a lot of GPs would have used in other contexts as well. And normally it starts off with a loading dose, so every 6 weeks for the first 2 injections, and then every 10 to 12 weeks, normally 10 to 15 weeks, normally around the 12-week mark. And then there's 2 options that are not on the PBS, which can be useful because Reandron is quite a painful, big injection. So these are slightly less painful, smaller injections. So Premoteston or Sustanon. I wanted to touch on, talk about fertility because that's a really important part of the consent process, is to talk about pregnancy plans in the future and fertility plans. So trans women who want to go on estrogen, so estrogen is much more likely to cause infertility than testosterone. And even if they stop hormone therapy for one reason or another, it might not be reversible. So I think it's important for people to go into it thinking that it's not going to be reversible, even if they change their mind that they want to stop, or they want to stop briefly for a certain amount of time. So I think it's good practice to always offer a referral for sperm freezing if they're at all unsure about their future pregnancy plans. Some people are they're 100%, they don't want a referral, they're not interested, which I think, again, is up to them at the end of the day, as long as they really know the risks and the benefits. With testosterone for the trans men, it's definitely, so you can't use testosterone as contraception because it doesn't reliably stop ovulation. And a lot of trans men have accidentally fallen pregnant if they're not having good contraception. And the other side of it is that trans men can cease their hormone therapy in order to start a family. So they might be on hormone therapy for a certain amount of time and then find someone they want to start a family and then they can stop the testosterone, have a baby quite safely, and then go back on the testosterone. And I don't think that there's not a lot of evidence about the long-term exogenous hormone exposure on sperm and eggs, but the data that we've got doesn't demonstrate evidence of harm. So monitoring in general, so again, Health Pathways has all this kind of stuff, which I refer to all the time. So I normally do monitoring blood tests every 3 months for the first year. And then once everything's stable, they're on the stable dose maybe every 6 to 12 months. And you want to monitor full blood count, EUC, LFT, fasting blood glucose, lipids, estradiol, testosterone, and all their biometric kind of things as well. And also do a psychosocial review to see how they're going. Annually, you want to also do a HbA1c and prolactin. And DEXA screening, I wanted to ask you, Jo, what your practice is as well, because the Health Pathways recommend the DEXA screening at baseline and then at age 60. And in practice, it's about $700 or $900 to get a non-PDS DEXA scan. So most people choose not to do it that I've talked to, or can't afford it.
Wow. It might be fortunate that Katie has now joined us, because I must admit that historically I haven't been doing bone density testing at baseline and later in adults. But more recently, since I guess being involved in the service for under 25s, where it certainly is routine, and my understanding is that we're encouraged to do this in adults as well. But look, I'm going to have a stab. My understanding with transfeminine patients is that there are slightly higher rates of reduced bone density, which may actually be present before starting hormone therapy due to other risk factors, like low vitamin D and perhaps less exercise and so on, as a young person, with gender diversity. And so then, to me, it does make certain sense to have that baseline test, prior to hormone therapy to establish if there's pre-existing issues, because really the hormone therapy, if it's provided at adequate doses, is protective for bone health. So shouldn't be too big an issue. But Katie, you're online now, and this is more I think, an endocrinologist's area of expertise than sexual health. So good one for you.
Thanks, Jo. Hi, Sujata. Great presentation so far. So look, I think you've got it in a nutshell, Jo. That certainly the evidence is that for trans feminine people, vitamin D, stress, lack of weight-bearing exercise leads to pre-hormone low bone mineral density. So after checking that their vitamin D is okay and replacing that, I would do a baseline, particularly if they're in their 20s, as you reach peak bone mineral density in your late 20s. So it's a good time to get that baseline. If it's low, it also allows you to check that you have got sufficient estrogen to improve a low bone mineral density. If it starts off fine, as the health pathway says, unless there's another indication, I don't do that again until 60. I think it's less important in trans men, but I do tend to get that baseline in their 20s if I can. But the evidence is that they don't have that preceding hormone low density, and the testosterone is certainly sufficient to keep their bone health. Most trans men don't have a suppressed estrogen while they're on testosterone anyway, so they still have that estrogen effect.
Thank you. Did you want to add I'm not sure when you joined, Katie, but did you want to add anything else from what we've talked about so far?
I came in about halfway through. It all sounded like really what we would practice. I guess the only thing I would say is, I think we need to really focus on what that individual's goals are, particularly in feminizing therapy. Some people want a suppressed testosterone, some people don't. And sometimes the people with partial goals are more challenging, in which case, we're happy to help with those individuals.
Cool, thank you. Yeah, definitely.
There
They're
are.
the people. Oh, sorry.
Sorry, I was going to say there are a couple of questions popping up.
Shall we?
Do you want to finish and do questions after?
Shall we just? Yeah, maybe we should get through the rest of it and then like have 5-10 minutes at the end,
Sure.
just in case they're answered as well. So we'll just keep on going with the monitoring. Again, so that I won't go into detail about the targets because in practice I look them up on health pathways all the time. But these are the general biochemical targets that you're aiming for. You want to be checking EUC and blood pressure after starting spironolactone, which is pretty self-explanatory. And the testosterone, yeah, so these are the peak and the trough testosterone targets. Also to flag that consider an ultrasound to monitor endometrial thickness after 2 to 5 years, someone on hormone therapy. I guess this is, again, just a flag that there's a pregnancy risk if someone's not on reliable contraception and they have a uterus and their partner has sperm. And also that testosterone is a teratogen, so it masculinizes a female fetus. So it's really important to talk about the fertility and pregnancy risk and all that kind of thing. Yeah, I think we've covered most of that already. Just wanted to briefly touch on screening. So basically for trans women, the screening is exactly the same as cis women. Once they've been on hormones for the 5 or more years, you just screen as per your usual recommendations for cis women. So every 2 years from the age of 50 to 74. And trans men, if they have breast tissue, then they should have screening as well. If they've had a double mastectomy, then they won't need breast cancer screening. And CST, if they have a cervix, then they should be offered CST. So every 5 years we do all this every day anyway. And self-collect CST might be more appropriate and more comfortable, especially for dryness. And you can use vaginal estrogen just before a speculum, which will help. And you might need to annotate the pathology form to avoid confusion in the pathology lab as well. I think Katie was going to talk a bit more about this framework, which is...
Yeah, and I would encourage everyone just you can access this online and have a look for yourselves. But I think that the good thing is that New South Wales Health, as part of the LGBTQI health strategy, has really taken a lead now in the trans health space and has developed this framework that's meant to guide primary care, tertiary care, NGOs, patients and families in terms of clinical decision making. Most of it is the stuff that we've already been talking about, but it might be particularly helpful just to have a think about those 16 to 18 and 18 and above populations and how they might be slightly different in terms of governance and what's expected in terms of, particularly for those 16 to 18-year-olds, having a multidisciplinary team approach. So I think this is great because prior to the framework, we were all working really with common sense and teamwork, but at least this formalizes it and therefore provides some protection around having a clinical guideline that's validated by New South Wales Health. Thanks, Sujata.
Oh, thanks. So I'll just touch on the other kinds of support and allied health referrals that you might consider with your trans patients. So obviously, if they're needing mental health referral and support, you'd be doing that. And there's often not all the time, but often sort of a bit of comorbid mental health, even a bit of even just anxiety and depression associated with the gender dysphoria, which often improves once they start hormone treatment. And I guess I just was thinking then I would really encourage GPs to to go into this space if you get the opportunity, because it's really rewarding type of medicine. Like you don't always treat people who just get like a lot of patients that I see who are trans who get they get their gender affirming hormone therapy, they just get happier and they have less emotional distress and they can come off their antidepressants. Like obviously that doesn't happen to everyone, and other people have other reasons for their mental health issues, but it's there's some lots of really lovely kind of examples of people who are actually just getting the kind of care that they've been wanting for years and years, and just very thankful, and their lives are improving and they're becoming more themselves, and it's really rewarding to see that. Also, I guess also consider endocrinologist or sexual health physician, and definitely for those under 18, I always refer to Maple Leaf House. Consider referral under 25 if they're a bit more complex as well. You can also refer patients to peer support groups or Trans Hub. If they're needing a surgical referral, then you're going to also need to have a psychiatrist referral prior to that, or a clinical psychologist. And then some people will request voice training as well. Also a plug for the Trans Hub doctors list. So if you're interested in this area, you want to see some more trans patients, then put your name on here, and that's a way that patients can actually find which doctors actually are gender affirming as well. And I guess support from a GP point of view. So when I first started off seeing trans patients, I joined the GPs Down Under Facebook, Gender Affirming Care Facebook group, and spoke with people that actually kind of had a mentor person who kind of guided me through the process for the first couple of patients, which I found really helpful. So having that support from other GP colleagues and other friendly specialists as well, such as those on the call today, really, really helpful, because it just gives you more confidence. There's also an AusPath email list, which is a very active email list of a whole multidisciplinary gender affirming care clinicians. There's conferences like the AusPath conference, and Health Pathways, again, keep on plugging it, but it's very useful. And also Trans Hub has some great downloads as well, like how to make your practice more trans friendly, including language guide, maybe looking at your client registration form, so making sure you actually think about that some of your patients will be trans and gender diverse. So asking what their preferred, what their gender is, what are their pronouns on the registration form. I guess it sets people up to know that they're going to be they're going to have a good experience in that practice. Another plug for Health Pathways, and some references. So I reckon I'll leave it on this screen, just in case anyone isn't already connected. But we should try and answer some of these questions, I think.
Yeah, fantastic. And I think, as you said, Sujata, you've answered a couple of them already, I think. There was a question about the PBS Authority for testosterone scripts, but I think you covered that. That for PBS access, you must have consulted a specialist from endocrinology, sexual health, or urology, and the indication is androgen deficiency with an established testicular disorder, because it's essentially absence of testes. I'm gonna throw the next two, I think, to Katie, because they're about there's tricky monitoring. One of them, which I always ask Katie because I don't know what to do with, is about when to be worried about prolactin levels. I don't know if you could sum that one up, Katie, or if it's quite a broad one.
Yeah, no, it's a great question, and I guess I have a level of comfort with higher prolactins because I see it all the time in my general endocrinology clinic. Essentially 9 times out of 10, it's often due to the progestin So particularly if you've got a patient on cyproterone acetate, that's often the culprit. We should always make sure, as I'm sure Sujata has said, that we've got the lowest effective dose of cyproterone anyway. So if a patient's on a higher dose, you can often lower that and you'll see the prolactin come down. Estrogen occasionally, if it's at a level beyond physiological, will also cause a raised prolactin, and as you would do, you would look at the other medications the patient's on, particularly things like antidepressants. To be a pituitary microprolactinoma that we would worry about, often there's a threshold of above about 2,000 units per litre where you start thinking, could this be beyond something medical? But if you've got an autonomously secreting microprolactinoma, the levels are constant and don't come down. So if you see that you've adjusted the medication and the prolactin level has dropped significantly, you can also be reassured. And otherwise, prolactinomas are not uncommon in the general population, although they're listed in our informed consent as something we consent our trans patients to, particularly on feminizing therapy. Equally as common in the general population. So if in doubt, refer on to us and we'll figure it out for you.
Yeah, fantastic. Thank you. And there's another monitoring question. Yeah, so of course the high prolactin we're seeing more often in the people on feminizing hormone therapy, but with masculinizing hormone therapy, we talked about that rise in hematocrit sometimes being of concern. And so the question was asked, what's the highest acceptable hemoglobin and hematocrit when on testosterone? And I find this interesting because several different guidelines, that I use have different numbers there. Hematocrit above 0.5, 0.52, 0.54, 0.56. So again, I don't know, Katie, whether you have a magic number. Above 0.5, I start thinking about, should I be adjusting therapy and considering transdermal rather than injectable, but I wouldn't be panicking until it's a bit higher. But what do you think?
It's a fantastic question, and I think does bring up that point that we need to consider all gender-specific reference ranges when we're treating trans patients. And on the whole, after about 3 to 6 months of therapy, it's probably more appropriate to use the reference range of the affirmed gender rather than the gender assumed at birth. Not all people want to put their affirmed gender onto the blood test forms, and some computer systems also make that difficult. So I think as a clinician, we've got to be aware of those things. Testosterone stimulates erythropoietin and suppresses hepcidin, so it's not a normal physiological response to testosterone that the hemoglobin and hematocrit will go up. And there's not one threshold that creates a risk. So the thing we worry about with a raised hematocrit is that there's been an association shown in the long term with the risk of clotting and the risk of cardiovascular disease. And in fact, when we look in the general population of cis women, that risk actually starts from about 0.42 of hematocrit, and for cis men from about 0.46. So it's well below the point where you would say the hematocrit is out of the reference range. The other complicating factor, and I'm giving you the long answer, the other complicating factor is that different labs have different reference ranges for hematocrit particularly, and we've done a lot of work with New South Wales Health Pathology that's ongoing around this issue. So I try and get people to do, if I'm concerned, I try and get people to do their tests at New South Wales Health Pathology because we've got more familiarity with what their cutoffs are. So you're right, international guidelines suggest we should worry from about 0.5, but that's not really well referenced data. Certainly, my magic number that I get worried about is around 0.54 on the New South Wales Health Pathology system. And then I think there's a kind of easy triage that you can go through looking at, was that person well hydrated? Are they overweight and obese? Because that can be linked, that can cause a higher hematocrit. Could they have obstructive sleep apnea? Because the risk is increased with testosterone. So if you've got other signs, such as daytime somnolence or morning headaches or hypertension, then I would do that next. Once I've been through that, we know that transdermal testosterones have a weaker link to erythrocytosis. So at that point, if I've been through that screen and I haven't found another cause, and of course, as long as the testosterone's within that physiological range, then I would consider swapping onto topical therapy, and potentially doing a JAK2 mutation analysis in case there is an underlying bone marrow disorder.
Very good. And I think I think we're kind of on 8 o'clock, and that the other question that I still had there was about where do GPs go for support when first starting out. And I think Sujata had an excellent sort of slide that listed some of the options, like joining OzPath and then having access to that mailing list, because there's lots of good information there. And I'm not sure if it was on your slide, but I think the person asking the question is already a member of the GP Down Under group for gender affirming care. So I don't know if there are other suggestions. I know that I joined, and this was very ad hoc, but a group of doctors who were actually spread across New South Wales and Victoria, and we met once a month and discussed tricky cases amongst us, and that was something that was very kind of helpful when starting out. I was very lucky to have a colleague, Katie, nearby, who was very open to the sort of phone a friend kind of approach, and I think I'm often, I'm happy to do that as well for people.
Does that group still exist, the informal catch up?
That one kind of fizzled. The particular group that that I was part of, and that was sort of run by Eva Jackson, who's a sexual health doctor in Sydney, but that was sort of not sure, maybe 4 years ago, and sort of over the next year or two, and I don't think it's still going.
There was I know we're slightly over 8 o'clock and we'll wrap up in a sec, but there was a question from a GP who couldn't actually make it to the webinar, but there's another local Armidale GP who was asking about the possibility of like a diabetes alliance style clinic, where the specialist would come to the surgery and you could sit in do case conferences. And I think I raised it with you guys, and it was a question of funding, but was probably the...
Yeah, it's very frustrating. I'm actually very hopeful that we might see funding for the over 25s at some point, because at the moment we don't have a service at all, really. It's just interested clinicians trying to work together to provide care. If the Ministry of Health does fund an over 25 service, then lots of exciting things could happen.
Great. Thanks so much for joining. I think Jenny, you're still there.
I'm still here. Thank you so much, ladies. That was wonderful. And thank you everyone for putting your questions in. I think we'll finish for the night. This will be up on our website probably within 24 hours, so please share it with any colleagues that might be interested. Thanks, everybody. Good night.
Thanks.
Okay.
Right, thank you.